that time of the season, and all through the house, everybody's doing something, playing ball outside, they're making music in the living room, a little mischief in the den. It's good to have everybody home again.
Are you going to try to follow me with that camera? Good luck. My topic is managed care and other issues affecting the aged in the upcoming election year. I think probably, let me ask first, how many nurses do I have here today? How many dentists do I have? How many physicians do I have? How many allied health workers do I have? Well, let me tell you something, folks. From my perspective, and I must tell you that the smartest I've ever been was when I graduated from high school. And it's been downhill ever since, I guarantee you. And the tumultuousness that's going on in the healthcare industry right now is unprecedented. And for you folks, it's probably the most difficult time that you'll ever be in your profession, trying to figure out what our esteemed colleagues in Washington is trying to do.
Who knows?
Right, exactly. And so I thought it'd probably be instructive to talk about a few issues, but I must tell you that I am not here to pontificate today. I am going to serve as a moderator. You are my colleagues. You probably know as much about your own particular area and what's happening within it. I will serve as a individual that will talk about a few issues, but like I say, I would like to have some participation in this because I think the viewpoints that you bring will probably make it a much more meaningful learning experience for all of us. So I'm going to throw up some issues, and I'll start out by saying a few things, but I hope more than anything that I think, I don't know, y'all please forgive me. I'm usually, as old as I am, the overhead projector is where I'm most comfortable. What is your name? Jeff, do not leave me, Jeff. No, that's okay. If I get there, that's all right. Jeff's saying, oh no, not another one of those. How many in here think they know quite a bit about managed care? How many in here like managed care? Sir, can you tell me why you like managed care?
Fee-for-service care is never having to say you know what's going on.
It's pretty profound. Would you care to elaborate on that?
Well, fee-for-service care, we've got 12 or 15 docs managing the patient, sometimes on 15 drugs. Nobody knows the interactions of any of them. Nobody knows what the other doc is doing.
Any comments? Continuity of care is there.
Well, we don't tell insurance companies how they set their premiums. You know, we object to them telling us how to set our fees.
Any comment? You're shaking your head.
They ignore our overhead. They don't know anything about it.
Okay, well, I'm not about to jump into that. Okay. Well, I hope more than anything that we have some differences of opinions in this group, and I hope that y'all will voice those opinions, okay? Some of the issues that we're faced with nowadays that are major issues are managed care. We'll talk a little bit about that. Medicare prescription benefits, nursing home issues, outpatient prospective payment system. How many of y'all are familiar with this little baby that's about to come on board? It is a DRG system, like inpatients, like inpatient care, that they're going to apply to all outpatient care. And that means that even more restricted reimbursement is going to go for outpatient care for providers, which means there's going to be reduced revenues for hospitals and other providers that deal in outpatient services. Medicare HMOs, what's happening with Medicare HMOs? Why are they all going away? Don't pay enough.
The thing is that I remember, I'm old enough that I remember when all this kind of started. And I remember in Cincinnati there was a managed care HMO kind of thing for the health department that took Medicaid and Medicare. Now, it didn't take a rocket scientist to understand that you're hoping that people don't show up until they die. Because if they do, you're in trouble.
You're in trouble.
Because they don't pay you enough money to take care of them.
Why?
It was just ridiculous.
Why would the government do that?
They're not right.
What do y'all think is happening right now in Washington? We've got Bush and we've got the other one. Did that tell you what it says about me? Excuse me, I'm sorry. I'm not prejudiced and I'm not selecting anyone or anything like that. But, I mean, we do. I don't know, you can read in the papers every day, and there's some of the major HMO companies that are dropping Medicare coverage. And they've been doing some research on that, and they have found that people, the elderly, over 65, will sign up for an HMO plan primarily for the limited prescription benefit that they can get out of that. After they have maxed out at that point in time, they'll usually leave an HMO and try to get with another one. But at the same time, the insurance companies are looking at what are the reimbursement rates that are being paid for Medicare HMOs. And they're ratcheting them down. And insurance companies are saying, hey, we cannot provide services for a population that demands such a high intensity of services. And so what are the ethical implications of that for our society? What are our priorities, say in Texas? Is a prison more important than health care? Is education more important than prisons? Where are we going to spend the limited dollars that we have in state? I'm sorry, where are we going to spend the limited amount of dollars that we have in our budget? And so our legislative group, our Congress, and all of them are trying to figure out where are the priorities. And who usually dictates the priorities? It's us, the people. And if the people, us, do not get involved in terms of really trying to understand what Congress is trying to do, and if we don't voice our opinions, i.e. by voting, then we are saying essentially the federal government is doing okay. Now, that's an assumption on my part, and I know that's wrong. But the issue is, what are the priorities? Patients' rights bills. Patients' rights bill. Patient privacy issues, home health care, Medicare fraud and abuse. And probably the one thing, folks, that all of you should know more than anybody is the effects of the Balanced Budget Act of 1997. How many of y'all are aware of this? We'll talk a little bit about it. First of all, I got to find out something here. I always give a little bit of test here. Y'all ready to take a test this early in the morning? Okay, it's going to be a managed care test. I chose a PPO over an HMO to have my PCP as part of the IPA after an RFP was completed by my employer's TPA, who manages our ASO account as a POS model. Paying physicians based on RB/RVS rather than PM/PM, using UR for high-cost services such as COEs. Now, y'all are all professionals in the healthcare field. Do I even need to ask y'all what all those acronyms are? You don't want me to ask you?
No.
Well, let's try. What's a PPO? And what does a PPO do? How does it work? Preferred Provider Organization.
That's a selective.
It's sort of a discounted fee basis. That's where you go in with a group of docs and say, hey, doc, I can bring you 5,000 clients if you will agree to a 25% cut on your normal and customary fees that you charge. HMO? And what are some of the problems with an HMO? What are the benefits of an HMO? This individual over here mentioned, well, you have continuity of care. You have individuals who are tracking a patient, supposedly, and less expensive for the patient. But you only have a limited number of physicians that you can go to that they've contracted, because the physicians that work within an HMO are employed by the HMO. So, if you want to go outside the HMO, then you're going to usually have to pay a penalty. Now they have what they call today point of service, where they do discounting with specialists that you go to or whatever like that. PCP, primary care provider. And what's another name for this individual? A what? Have you ever heard gatekeeper? Have you ever heard the term gatekeeper? If you are a part of a PPO or an HMO, you have to be assigned a primary physician. And that physician will make an initial assessment of your health. And then he or she will then determine what type of services you're going to receive. So a primary care physician is a gatekeeper. If you're going into the managed care arena, this is the individual that you will first have contact with, who will then refer you to specialists and the various other health services that you need. RFP. How many of y'all have written research proposals? Request for proposal means that you are trying to develop a proposal that meets, say you're starting an HMO or a PPO, then you have to have certain state and federal requirements that you have to meet. So a request for a proposal is part of that.
You missed that.
Oh, I'm sorry. IPA. Independent Practice Association. This is a group of doctors that get together and say, okay, we feel like that we should have a group that can negotiate with the managed care companies to make sure that we're not taken advantage of, and that we will have a group of physicians who have specialties across the whole spectrum of medical care, and therefore our power will be much greater. Request for proposal. I'm sorry, thank you. Too early in the morning. ASO. That's Administrative Services, I can't think of O right now, account. And that's where you have some companies that say, okay, we're going to, for the managed care, we're going to deal with all of their billing practices. We're going to set up how they go about billing patients and how they go about providing the services. And you have all kinds of insurance companies and other groups that do these kinds of things with managed care. Point of service, I had mentioned that. ASO account as a point of service model. Let's say that you're a member of the HMO and they have a point of service clause in that. What they say is, okay, If you use our physicians, you get 100% coverage. If you go outside our HMO and you go to a specialist, then you're going to have to pay 50 to 75% of the cost yourself. Folks, we're moving to a healthcare system where the patient is going to be more and more responsible for healthcare cost. And there's going to be an outcry about that. Paying physicians based on RBRBS, that's the old DRG system. And also relative value system for physicians, where they say a specific service rendered by a physician is on a fee schedule, and that physician will be paid that amount. PMPM, per member per month. The basis for managed care is that you, as clients, will pay a certain amount of money each month, and you will receive a certain amount of services by that managed care entity. Utilization review. Using utilization review, if a healthcare provider is going to sign up with an HMO or a PPO or whatever type of service, usually that managed care entity is going to say, we want to review your records. We want to make sure that you are doing the right thing in providing services. For high-cost services such as COEs, cost of excellence, centers of excellence. Centers of excellence are saying where you might have heart transplant center, lung transplant. These are very high-cost areas, and managed care entities are very, very sensitive about those. Any comments? Here, let me throw this back on.
Yeah, I'll make your comment.
Great. Now, don't let this man talk all night. Surely some of y'all have got some comments. I see that look on your face, young lady, and I just see all kinds of comments coming out. Yes, sir.
Well, I don't really know the
Excuse me.
answer to it. I'll tell you that. And the thing is, though, the doctors are subsidizing these programs. And then I'll tell you another thing is that, of course, that there is some automatic billing, I know, and I'm sure that's helpful, but that's a cost too. And they hold up their payments for maybe a month, 2 months, and that's riding the doctors. We don't like that. I don't. And I'm not happy with this whole program at all. No way.
Well, I would be the first one to agree with you on that. I think the controls, the situation of managed care being that now, folks, it's not the docs, it's not the administrators who run the system now. We are on the lower tier. It is employers. Every employer here in town has a benefits officer. And that benefits officer has probably worked in the healthcare field for 20 or 30 years as an administrator or someone else. So that individual knows every cost in a hospital, by the providers, etc. And this employer, who might have 10 or 20,000 clients, is going to determine what type of insurance they receive. So when that employer comes up to Methodist Hospital with their health benefits officer and says, we want coverage for 10,000 clients, what are you going to do for us? We have examined the services that you provide. We have examined the physicians that practice at your facility. We've examined everything about your facility. And we've been looking at your cost, and we think that you can provide us health care services 25% below what you're providing right now. And if you do not reduce your cost by 25% to us, then we'll go over to the Baptist hospital system and we'll do a deal with them. What does that do? What are you going to do? when you're talking about a bottom line, keeping your facility going, and you have all of these people that you're relying upon come to your facility to keep you running, and there's a possibility you're going to lose them to somebody else. You do the only thing that you can, folks. You cut costs. And you try to figure out how you can streamline your services, and it all comes down to putting more and more work on your people. Reducing staff, trying to figure out ways how you can provide those services more economically. But at the same time, what are you doing in terms of sacrificing the people that work for you? And that's a cold, hard fact. That's competition. Healthcare industry has been turned on its ear. Fee-for-service wise, you try to get as many people as you can in the organization or in the healthcare facility and provide the services. Physicians are captain of the ships. Administrators determine what type of services, etc. And you go from there. And now the government and its reimbursement policies that we can see with Medicare, Medicaid, state, are the ones that run the system. And they have individuals up there that possibly may not understand the consequences of their actions. But the politicians are saying, cut cost, cut cost. And you say, well, why? Why is this happening? Well, how many of y'all are aware of the fraud and abuse statutes that's going on in our country right now? Our credibility with the public, with those who reimburse our services, just about nil. The world's largest hospital corporation, Columbia, I don't know how many of y'all have Methodist, conjunction with Methodist. They've now changed their name to Healthcare Company of America.
Why?
I don't know. I think that I was just thinking about the chairman of the board. And of course, when Columbia was hit with the fraud and abuse, and it's right now they've already paid like $775 million. They have $1 billion war chest, but it's just now beginning. And I think they're thinking that if we change our name, then maybe people won't associate us with that situation. You see, that's usually the way corporate does it. But you look at that, and the federal government comes in and they find out where so many providers, so many hospitals, the healthcare industry as a whole, have come in and abused their system. And the politicians look at that and they say, this is ridiculous. And so we're going to put the quietus to them. Don't ask me to explain the quietus. It's just something that came out of West Texas from where I do apologize from a New York accent. Okay? But, and I hate to be so deadgum regressive, I think, in my comments and everything, folks, but it's something that I hope that y'all will discuss, and I'd like to have a discussion here too in terms of the fairness and the unfairness, of what's going on and how it affects us as providers. But I feel very bad when I look at my students in class and I'm talking to them about fraud and abuse. And I look at my mother, who lives with me, who's a stroke victim, and at one point in time where she could receive home health care services, now they have cut back on that. And I think, gosh almighty, the Congress has really slammed us, but at the same time, what have they done to the patients too? And so I don't know if the pendulum has swung too far to the left and now is it going to swing too far to the right. It'd be nice if we could find the middle ground. But right now it's election year, folks, and no politician is going to touch an issue as volatile as health care. Certainly Bush and what's his name are going to talk about prescription drugs. But they're talking about $40 billion for prescription drugs to include. But do you know what they're going to do with that, where they're going to get that $40 billion?
Social Security.
Out of your pockets. They took $117 billion out of the healthcare system in 1997. You need to to understand what that did to us in the healthcare field and what is happening right now, the reverberations that have resulted from $117 billion taken out. Last year they put in $18 billion. This year they're proposing $40 billion. But the $40 billion, there's a fight between AARP and the providers in terms of who is going to get that pot, even if it's going to be $40 billion. Yes, sir.
How did they take that money out? What mechanism did they do to take $117 billion away?
They did it by reductions in Medicare payments, payments to providers, and that was the primary reduction there. The reduction that you're seeing right now, the insurance companies getting out of Medicare HMOs. How many of y'all seen the staff reductions in every hospital we have here in town? Have you seen that carnage? And here we're about to go into that situation again. And a lot of providers are hoping that that $40 billion we're talking about is going to be something that helps kind of revive us a little bit in the healthcare industry. But again, the politics of it are, do we give this money to the Medicare beneficiaries for prescriptions, or are we going to try to divide it up and give it some for providers so they can provide more services and get a little bit more reimbursement? So that's a political firestorm that politicians are really trying to avoid at this point in time.
Dentistry's not involved with Medicare.
You know, it's interesting about dentistry. Why has dentistry been protected to a certain extent?
Because half the people in the United States don't even have dental insurance, so most of dentistry is fee for service. I mean, people just pay for it.
What would be the cost to the federal government? Billions. They're not going to touch it. They will to a certain extent. You find some corporations that are developing dental HMOs, entrepreneurs, et cetera, that are looking at, well, are the dental schools turning out so many dentists that, just like a doc, can you imagine what it would cost for you and to go up to a banker and say, I'm a doctor, I'm a dentist, and I need some money to start a practice. And they'll ask you, well, are you going to be with the group? No, I'm going to be an independent. And he said, well, don't let the door hit you in the behind as you leave.
Not where we
Poor
live.
investment.
Not where we live.
Where do you
If
live?
you're in Carlsbad, New Mexico.
Are you from Carlsbad?
Yes. But
I'm from Jow.
no kidding.
Yes.
How about that? Well,
Y'all, we're talking about, everybody used to say, well, you're from New Mexico. That's a beautiful state. You've never been to Carlsbad or Jow. It's the worst of it.
Dr. Joe one time. Smith.
Yes.
Yeah. Anyway, what I was going to tell you now.
About a dentist that out in Carlsbad, out in the area that you're saying, that a dentist can start a practice. Completely different situation in rural areas.
All you need, a physician or a dentist can go into a bank and all he needs is a degree. And he can borrow in Carlsbad.
In Carlsbad. Okay.
All you need. And any doctor can go into the banks and borrow on his degree because they know he's going to be successful.
Yeah.
One way or another. Whether he works or not works. He really needs to work.
Well, I think here in San Antonio, the opposite is there. If you're going to be part of a group, yeah, that's great. Because they're going to have to subsidize cost, and the bankers don't have to put so much. But for you to go into private practice here, they're saying, well, there's a dentist on every corner. There's a doctor group on every corner. So in order for you to pay back your indebtedness, you're going to have a certain number of patients. And you're going to have to guarantee us, where are you going to get your patients to pay back your debt that you're borrowing to set up a very expensive office and equipment and stuff like that. Rural areas are entirely different, folks, and it's something that is concerning a lot of people that provide services out in the rural communities. Because managed care is starting to penetrate the rural areas. And how many of y'all have heard the term cherry picking? Cherry picking means that you're getting the very best of the crop. So you have a managed care entity that comes into a rural community and they locate all the private pay patients. Medicare, Medicaid, I don't think so. And there's that hospital, that rural hospital, that's depending upon those private pay patients to help keep them afloat. And when the managed care entities are successful in taking away those clients, then the health care facilities that are available, health care providers available in the rural community are gone. And so right now, we're watching a bunch of rural communities thinking about closing their hospitals. Not just Texas, it's all over the United States. And so here we've got another problem looming. You know, what are we going to do about health care in the rural areas? I mean, we got it here, you know, in the metropolitan areas, and certainly we have enough restrictions on us and ratcheting down of reimbursement. But what are you going to do when you can't even keep any providers out in the rural areas? And so here we go. We've got a political system that's saying, okay, well, let's go down this road. Let's do it by incrementalism, and we'll just wait till somebody screams loud enough. Rural areas, constituencies in the rural areas, AARP, etc. And whoever we have to please the most is going to ensure that we keep our position in Congress. That's what we're going to do. Now, I know I sound like I'm berating politicians. I'm glad I'm not a politician. And I know it's very tough for them to make decisions. But it seems, though, as though we do not have any type of rational health plan that we're trying to develop for the future. And it's a little bit scary in terms of just cut, and no, not even an afterthought about that. And that Balanced Budget Act was the one that killed us. Now, at one point in time in our industry, folks, private pay employers were the ones that covered most of the cost for us as providers. And Medicare and Medicaid was the ones that lowballed us. Now the private payers have become so sophisticated in analyzing what we do as providers that they are now lower reimbursement rates than Medicare and Medicaid. So all of a sudden it's kind of switched in the last couple of years that you're looking for your profit from Medicare and Medicaid. You were until that, I'm sorry, I said 117. 112 billion was cut out. And so all of a sudden, have y'all ever heard the term cost shifting? Cost shifting. Shifting cost. Everybody asks, you know, why does an aspirin cost $10 in a hospital? Why does a box of tissue cost $5? Well, my gosh, if you're going to do heart surgery and they're going to lowball you, Medicare, Medicaid is going to give you $5 for heart surgery, and they're going to allow you to shift that cost over to make it up, then what are you going to do? You're going to have to make it up somewhere, or you're going to have to close your doors. And so hospitals, providers, in order to keep services going, some services that are reimbursed way below cost, the federal government will allow that provider to shift those costs to other areas. So in reality, somebody says, well, why am I paying, $10 for a bottle of aspirin? Well, that's because the heart surgery that you received, or some of the American people received, is being reimbursed at 50% below cost. So you have to make it up somewhere. So that's the cost shifting that goes on. Now, the cost shifting, Medicare is cutting back. Private payers are cutting back. And so what are we to do? Downsize? Find better ways of providing services? Provide health care in an entirely different way? We have to do that. If we don't, we won't survive. So new ways of doing business, new ways of providing services. In the rural areas, if a physician will not go out into the rural area, why not train a nurse practitioner or a physician's assistant to help provide some services? And maybe provide an intermediate hospital So if that individual suffers some medical malady, that at least they'll have immediate services and maybe connected to a major medical center where that individual can be transported, or a physician can give the physician assistant or the nurse practitioner some advice on how to deal with people.
They're doing some of that.
They're doing it all over. They're doing it all over. But you find in specific states that the licensure laws really restrict some of that. And so you may have physicians who say, okay, nobody can provide services unless they're under the direction of a physician. Well, we do that in Texas. We get around that by the corporate law that we've set up of medicine. A physician can work for a corporation if the corporation has a physician that's part of that. Now, folks, some of our extra money that we've been receiving, the cost shifting that I've been talking about, has been from some of these areas here. Skilled nursing services, rehab, home health services, etc. Now, what they're going to do, the APC, which is the ambulatory classification, DRGs. Okay, thanks. Is this one of those lasers that kills you if you turn it on? Here, keep it, please. I'm too old to deal with that kind of stuff. Oh, God, praise that. Congress and them right now have a group of individuals that are trying to develop, I said the DRGs for the inpatient services, and the ambulatory care classification would be like the DRGs for ambulatory care. They're going to have DRGs for rehab, home health care. They're going to have all of them. The DRGs simply means, folks, is that the federal government is going to say for a specific service that you provide, you're going to receive X amount of dollars. If you provide a rehab service, let's say, physical therapy for a stroke victim, you're going to receive $20. We're not going to take what your customary charges are, which were $50. We have determined that you will now charge $20. And so individuals look at their cost statements, they look at what they're trying to do, and if they can't get their services down to $20, then they had to say, okay, I guess we're going to have to go out of that type of business. And there's a bunch of them that are starting to do that, saying, I can't provide services at that cost. So it's coming down to crunch time, folks. Somebody's going to have to give, and it's election time. What?
They do shifting, like you just said.
Yeah. What I was saying, though, what the problem is that we've been able to shift. But now they're taking everything that we've ever been able to shift to, and there's no room. There's no room. So what is a healthcare organization going to do? Bless you. Is it going to try to deliver medicine, healthcare, in a different way? Is it going to be a challenge to all the traditional ways that we, in a hospital setting, that you have 50 different types of professionals, each of them have their own codes of ethics, have spent 50, 60, 75 years developing how they're going to provide services, and now you say, you can't do it that way anymore, folks. You've got to do it a different way. So the challenge is for us to try to figure out, can we do it or can't we do it? Is it in our education? Do we need to reconfigure how we train administrators, physicians, nurses, etc.? Is it a situation in medical school now that docs, before they can graduate, have to go through a business class? They have to understand the economics. But yet technology is moving at such a rapid pace. Does that mean a doc's going to have to go 5-6 years?
Yeah, they all teach it in dental school and medical school.
Yeah. Yeah, they're right. Yes, well, I mean, I am come in here and I have just, I made a scenario that I probably depressed the heck out of you this early in the morning and everything else. And I didn't mean to do that, folks, but I do mean, golly, I think one of the most important things that we can do as professionals, and I'm right there in the boat with you, and I look at those young kids in front of me, and of course they don't carry the baggage that I do. I don't remember the good old days. They don't remember, the cost shifting, the relationship that you used to have with insurers, etc. All they see is a very competitive environment, and that change is the rule. It's not the exception. And so how do we as professionals develop change as an important part of our profession? And so how do you do change? Well, change is done by understanding the changing healthcare system that we're talking about, the issues that are going to affect each and every one of us as we move through, and learning about what is happening, what people have done in environments that have worked, learning from individuals who have tried new techniques, new styles that haven't worked. And so it is incumbent upon us, colleagues, that we really do have to embrace change, and we really do have to learn how to do things differently. But understanding the system we're in is the most important thing, and understanding managed care is one of the most important things that you can ever learn, because we are moving to a point where we are going to identify every penny that is spent on every prescription, every service. They're going to be doing the old time and motion studies on your work in terms of providing a service. How many minutes does it take you to get to the room? How many minutes does it take you to provide that service? And so the minuteness of this is depressing. But I always say, if you're at the forefront and you're the ones that are making the change, you're the ones that are determining who's in better shape to do that. You're the providers. You're the people that know more about it than anything. And if you don't, then someone else, i.e. the insurance companies, the employers, will hire their own people to come in and do that. And they know it doesn't mean they're going to come into your facility, but they're going to be looking at all your records. They're going to be looking at records from all around the whole country, and they're going to try to develop standards. And so what is a provider to do? Provider is to take the initiative and say, hey, maybe we can do this a different way. Why can't we attend a few more seminars in terms of efficiency? How can we attend some seminars on how to motivate individuals? What type of leadership is really needed to make sure that we're going to be able to compete the next 10 years? I'll shut up. I always do what I'm not supposed to do, and that's pontificate too much. I am very much concerned, though, right now at this point in time. The one thing that I want my students that I have to really understand is how important ethics is. Certainly all of us have financial accountability, for our institutions' respective areas. But we also must never forget the social accountability that we have, too. And I think we're moving into an era now where everybody is pressuring us as providers to cut cost. And here we are, the ones that are closest to the patient, to the client. And we're having to treat 5 clients instead of 2 clients. And the clients and the public have grown accustomed to a certain type of care that they've received in the past. Somebody giving birth to a baby, and somebody in Washington says, okay, they need to be out of the hospital in 1 day. Those kinds of things that are going on. And of course the medical establishment speaking up and saying, hey, you're putting these mothers and that baby at risk, and you shouldn't be doing these things. So that's one reason why providers should definitely make sure that we're getting involved in terms of the types of decisions that are going to affect care for Americans. Yes, ma'am.
What you're talking about, my son is a nurse in a cardiac ICU in Amarillo, and they have had traditionally 1 to 2 patients that each nurse is responsible for. He said, but they're cost cutting and they're going now to 2 to 3 patients. He says, and what happens, if all of them go south at the same time? He said, you can't do it. They're taking their secretary away. He works a night shift. He said, they're taking away our secretary.
I know it.
So he said it's really getting pretty scary.
And you also, you look at the leadership. What is leadership doing? Administrators, anybody that has a leadership position, in the healthcare field should be working 24 hours a day, 7 days a week, by trying to analyze, where are we going, getting the providers involved in what can we do and what can we not do. And I think that the leaders that are not doing that are doing their people a great disservice. And not to explain to your people, whether you're a department head, whether you're a supervisor or anything else, what is going on in the healthcare field and why you're doing the things that you're doing, and at the same time having input from them and not coming down and just saying, cold cut, you got to take care of 5 patients now instead of 2. Explaining why. What is happening in the healthcare system? Why? What is the competitiveness? What are the other hospitals doing? What's going on, that we need to do to make sure that we can provide a service where the patient benefits and we also get some benefit out of working for this institution. And leadership is through the whole continuum of the organization. It's not just at the top, it's everywhere.
I have a number of things you said over the past hour that brought things to my mind. When I came down here on Sunday, I was down here, one of the last people I spoke to was a physician who practiced out in the western part of the state.
Whereabouts in?
Well, I live in New Hampshire. I work in Massachusetts, New England, let's say. Matter of fact, those 2 guys you were talking about, Brian, one's from Harvard, one's from Yale. And I don't know whether that's a problem.
Right, the hell
Maybe that's the problem. I don't know.
the top business programs in the world, so go ahead.
Yeah, well.
Yeah.
He's a hard-working doc, always working, busy, and he offhandedly told me that his company was going out of business. Okay? So I said, why do you worry about this, John? And he said, no, what I'll have to do is I'll have to go to the bank and get some sort of loan and just reopen. I mean, obviously his patients are there, and the way the finances are, it's killed his company. Now, theoretically, this is elderly. We're talking about people who don't have jobs. Today, so are you saying that the people in business and the people in the government are doing the same thing? Driving prices down, for whatever the reasons are, in concert or separately? The elderly, we had a something thrown out yesterday in the very last class about people who were over 75 and had heart attacks, 1/3 of which didn't get so much as an aspirin. And maybe that's the reason these people didn't get an aspirin, is because the damn costs just don't support treating them. Not because the docs didn't know what to do.
Right.
I know there are a number of things. I don't have any questions here. These are just things that have come to my mind as we've talked. And I don't have a whole lot of them.
Yeah.
But,
That's
it was something that I will talk to about the 2 patients versus the 5 patients. Out in California, Kaiser Permanente, about a month and a half ago, finally got around to seeing her, and she had a descending aneurysm. Didn't make it through the OR, and the government body determined that a pageant permanente was at fault for $2 million. Pageant permanente was gone to fight in court. But, I mean, this is where we are. This is a situation where the government basically cuts down the amount of people who work in the healthcare field that have certain earning wages, and then fines you for not being able to see somebody in time.
Right.
I don't know if people in HMOs would be able to, or that much smarter that they would know about 15 drug interactions versus people in private practice who can't follow the leader. But just yesterday, just dealing with one organ system, let's say the heart, blood pressure level, you may be taking 3, 4, 5 cardiac medications, and all of a sudden I learned about a drug that to restore taste, maybe you would have to take a medication for that, so you're up to 5 to 6, and I haven't even covered any others. I mean, at the same time, there's no way to get around taking a lot of medications. Today where I work, it's a geriatric facility, and you have JT that is managed, and guys come in with 17 minutes anyway. So I don't know if there's an easy way to say, oh yeah, this works for them.
Excellent statement of some of the issues that we're facing. You know, the HMO, the Kaiser Permanente, they have laws that says that the patient cannot sue the HMO. And that is the major issue that we're seeing right now in the papers, et cetera, is can an HMO be made responsible for its decisions, medical decisions, legally liable? And the federal government is not too much in favor of that. Why? They've got a vested interest. HMOs, Medicare HMOs. And where are you going to find most of the errors? Treatment of the elderly. You have complications when you're dealing with the elderly that's unbelievable. And the cost is unbelievable if you're going to provide the services that are necessary. But if you've got a doc and you hire that physician and you say, Doc, this is what you're going to have to do in this HMO. You're going to have to see a certain number of patients. You're going to have to follow utilization review, and you're going to be a... But Doc, we're going to set aside $200,000. Now, Doc, you can use that $200,000 that we've set aside over here to make sure that the patient has additional services that they need. If he needs to go to a specialist that's outside the HMO, etc. Doc, if you don't use any of that $200,000, the organization's going to get $100,000 and you're going to get $100,000. Now, what kind of ethical dilemma do we have here, folks? And so to the public, as they sit out there right now and they see Columbia, they see nearly every dead-gum hospital getting nailed for fraud and abuse. And then they say, what? You're going to pay, a doctor's going to be rewarded for not referring, for not using that amount of money, or somehow trying to ensure that he or the company is going to make additional monies. Seems to be a little bit of conflict. And so the American people, and at the same time, folks, I'm going to tell you, there's a bunch of good docs out there. And the HMO principle, if it was carried out in its full purpose, would be an excellent service. Primarily because, one, you would have a physician that would track the patient, but a physician that was ethically inclined would make sure that that client was taken care of. But at the same time, that physician would also understand the cost implications of his or her medical decision. And so the leadership should be able to understand when we talk about per member per month that if you're going to get $50 or $60 per month from a patient to provide a certain amount of services, you should really do a lot of studying to make sure whether or not you can provide those types of services, or certainly not resorting to that, well, we're going to put some money up here as a little perk for the physicians if they won't provide the services. I don't think that's the way our healthcare system should be run. But there's a lot that says, well, let's put some competitiveness in it, and let's make sure that it's done that way. And, you know, one thing that you look at this, folks, I think that the American public does not realize that when we get into these DRGs for all of these various services, that there's going to start becoming a copay. You know what a copay is? Copay is what comes out of the public's pocket to provide services. And the federal government is moving forward in terms of ratcheting down payment. And when they ratchet it down, then they're going to make us as the providers say, okay, you can charge them a 20%, a 30%, a 40%. On these APCs, on these ambulatory care DRGs, they have some of the respiratory therapy treatment modalities, and they've got and they're right now in the comment section of that on the regs, and some of the facilities I was talking with, they provide the service for around $450, $500. Hyperbaric treatment. We got a physical therapist here, or a respiratory therapist. Anyway, that modality, and they figured their cost at $450. Well, the federal government has sent back saying, well, we're going to reimburse that at $120. But the real thing that's in the reg says is that there's a copay on that, and that the federal government is going to pay $20, and the patient's going to pay $100. So, you know, when the public gets this type of scenario, then you're going to see a bunch of politicians hopping around real fast. And maybe that's the best thing to deal with health care, is to get the patient involved. And it's sad that, you know, that we have individuals, Medicare people, elderly, Medicaid, that we have to go to that draconian measure to prevent them from having services until we get, you know, an uproar by the public. And so how many people are going to be hurt until that pendulum swings all the way back over? Nobody can keep it, you know, on a stable thing. So that's about all I have to say, folks. Comments and everything else, again, in closing, the one thing is, golly, read the papers, read up as much as you possibly can in terms of what's happening in the healthcare system. Learn as much about managed care as you can, because I can tell you managed care, to a certain extent, is going to be, it's already in some markets, the predominant delivery system. Simply because it is the system that tracks and identifies cost better than any other system that we have at this point in time. So if we're going to have to function in that type of environment, God's sake, let's make sure that we understand the implications of dealing in that, and how we're going to survive, and how we're going to provide better services. And most important of all, how we, as a profession, make sure that everything that we do is ethically sound. Thank you, folks. I hope it was interesting. Any comments or anything?
Well, it's that time of the season, and all through the house